The biopsychosocial approach to disease and illness, the natural history of disease and the psychosocial types of illness. Part 1. The biopsychosocial approach to disease and illness. And the question is, why is this such a big deal? Why are we even talking about it? Why is it such an important thing to the generalists? What do I mean by generalists? Those who are not specialists. Those doctors who decided that they'll devote their lives to a more general approach. The specialist stays in these big, nice hospitals, gets well known, gets awards, gets published in the newspapers and journals, and people look up to them. And of course, we want that. And there's fame, there's prestige, there's even money involved, and we would want that rather than the GP. And that's exactly what happened. What happened was the general practitioner, or the practice of general medicine, is becoming less and less significant, less and less important as far as everyone is concerned. And the specialist care, which is very much disease-oriented, biomedical, bio-disease-oriented, is becoming more and more significant. And everyone was thinking probably the general practitioner would disappear in a few years' time. And what we need is a doctor who does the science, who does the technology, figures out what this disease is all about using science, and comes up with ways to diagnose it and treat it. And if he can solve all the problems, then everything will be gone, right? So everything will be fine. Now, the general practitioners during those times, of course, they have their group, their society and academy, but nobody pays attention to them that much anymore because the big ones are the specialist groups. They felt like there's something wrong with the situation. First of all, they don't want to go extinct. And secondly, they don't think it is a good idea to make the generalist perspective go extinct. What they're saying is, science is good, technology is good, but that's only one aspect of care. And if you just focus on that and downplay everything else, then as far as they're concerned, we won't be delivering good care and we won't be very effective. That's their perspective. And so this generalist group tried to lobby and try to convince everyone, the government, the medical institutions, colleges, hospitals, training institutions, and organizations of medicine, and even the specialists, that when we train and teach and educate the future doctors of this country, we should still try to preserve and teach them the other stuff aside from the scientific, the reductionist approach to medicine, meaning the stuff that they're doing, people stuff, taking care of the people, talking to the mom, talking to the kid, trying to figure out what the problem is that's specific to their community, try to figure out the best way to approach this problem using the other family members, trying to talk to this person one-on-one because each person and each patient is unique. That approach, they felt, is being lost by this new, big, modern, scientific medical approach that's being taught in med school. And of course, the next question is, how are we going to teach that? So of course, that's the next question. And you can imagine the specialists saying, well, that's all good and nice, but that's art, that's not science. I mean, how can we teach that? And how can that be systematic? It has to be systematic, so it has to be organized because that's how we teach stuff in med school. And of course, it's not just art. It's just that it's not biological science. It's not just purely biomedical science. You're actually talking about psychology, sociology, the application of public health, nutrition, mental health, and things like that into the practice of medicine. Because the problem with the new thing, the new scientific approach, is it's more focused on the disease and it's less focused on everything else. Now, if we're going to give this a name, what do we call it? Dr. George Engel is not a general medicine doctor. He's not a family medicine or a community medicine doctor. He's a psychiatrist. And but what happened was he noted a lack of regard for processes which operated over time to allow for healing. Meaning, he's looking at these specialists and these very scientific, very technologically savvy doctors doing their medical care. And he, the psychiatrist, noticed there's a lot of things that they're missing out on. And these things, as far as he's concerned, is very important in the healing process. And they're doing all the right stuff as far as the biological assessment and the biological treatment is concerned, but they're missing out on a lot of psychological and social reactions to illness, which played a very important part in the healing and the recovery of the patient, especially those patients that he was exposed to. And usually these are patients with chronic diseases. Now, of course, the generalist medicine doctors, the primary care doctors in the field, in the community, also are saying the same thing while they're doing their community work, their primary care work. When they treat people with their illnesses, the thing that decides whether they get better or not is not just the surgery or the drug that they give, but everything else in between. Same idea as Dr. Engel. And so they both agreed, the psychiatrist and the generalist medicine doctors both agreed that there should be a holistic, a comprehensive, or a biopsychosocial approach to assessment. Of course, you notice that there's something missing in the biopsychosocial. So recently, 20 years ago, people started proposing the last dimension, the spiritual aspect, which is also very important as far as healing and recovery is concerned. So now we have the biopsychosocial spiritual model for assessment and care of diseases. And so the question is, this holistic, comprehensive, and this biopsychosocial idea, how do you present this in a way that's understandable, systematic, organized, so that we can do research, we can study, and we can actually teach the trainees and the students in a way that they'll understand as organized and as systematic as the other scientifically inclined specialty fields. Now, one of the popular approaches is to consider interacting elements. So, meaning you have the disease and the illness, and this disease and illness has biological, a psychological, and social characteristics, and interacting are causing problems to a patient who is reacting biologically, psychologically, emotionally, and socially. And this family, the other element, is reacting to the patient who is sick, also psychologically, emotionally, even biologically, and the disease is affecting the patient. Now we can even put in another element, which is their neighbors in the community reacting to the problems of the family and the problems of the patient, or the disease affecting multiple families in the community. Some doctors or some scientists will also include the medical doctor or the healthcare institutions reacting to the problems and the problems caused by the disease on the family members or the community. And so you have these different interacting components. Now, my job is not to discuss each and every component. My assignment is to talk about the disease and illness, but we're not going to talk biochemistry, pathology, pathophysiology, because that's an entire semester's worth of lecture, and that's not my field. Instead of going micro, doing the reductionist specialist approach, what we're going to do is we're going to look at the disease and illness from a more broad generalist perspective approach, macro. And there's lots of ways of doing this. For the past 20 years, what we've been using is something out of epidemiology. Of course, we can come up with other things, but you also need this lecture. So we try to hit two birds with one stone. So we're going to use this one is the natural history of the disease. The idea is there's this progression of disease process in an individual over time in the absence of treatment. So if a disease enters a person and you don't mess around with it, what happens to the disease? And then we can come up with the history of that disease. Well, first, there's going to be the disease that's not in the individual. So you just have a person who's susceptible to the disease. There's disease floating all around the place. And then the individual gets exposed to the disease. So the disease enters the person, but he's not feeling anything yet. So if you ask the person, are you feeling anything? He actually doesn't even go to the doctor because he doesn't know. He thinks he's okay. He doesn't complain about anything. You ask him a list of symptoms. He says no. So he's subclinical. Now, once the disease progresses, if the disease doesn't resolve, if it progresses, then he becomes symptomatic. He starts feeling something. He starts having problems. Then he complains. If you ask him, then he'll give you a list of symptoms of what he's feeling. Now the disease becomes noticeable, or the disease becomes clinically manifested. It's the stage of clinical disease. Now, as the disease progresses, remember, in the absence of treatment, so we're not doing anything, we're just letting the disease go. If we let the disease go, then disease will actually end up either getting better on its own, so the patient recovers, or the patient recovers but the disease does some damage, so that's disability, or the patient dies. And that's the stage of outcome, the stage of recovery, disability, or death. That is the simple, very easy to understand natural history of disease. That's part 2 of your reading material. Now, the first picture is a baby. The baby is looking up, and the doctor is holding a syringe with a very, very long needle. Now, the baby is probably looking up because the mom and the doctor is telling the baby, well, look at the toy with brilliant flashing lights. Of course, the baby has no idea that this long needle is about to enter his leg. And it contains a vaccine, about to enter his leg and inject a vaccine. Now, we're not interested in the distraction technique being used by the doctor and the mom, so, and hopefully the baby doesn't cry too much. And we're not interested in the vaccine itself. That would be the job of your other lecturers, not me. That's not my field. But what we're interested in is in the stage of disease. The reason why we're giving the vaccine to the baby is because he doesn't have the disease yet. He doesn't have the clinical disease or the subclinical disease. He does not have any disease, but he's susceptible. He can get exposed to the infection. And hopefully, after getting the vaccine, the baby becomes immune and he doesn't get the disease when he gets exposed to the infective agent. So we're talking about the stage of susceptibility. Another example is a young kid. He's been smoking for about 3 to 4 months, and he approaches the doctor because he's been trying to quit and it's not working. He's asking the doctor if are there any behavioral ways of doing it, or systematic ways, or structured ways, or maybe there's a medication that can help him out. And so the doctor asks him if he has any symptoms, and she runs through the list: coughing, shortness of breath, and things like that. And he says no to all of them. So he has no clinical manifestation of the disease, and assuming, of course, we can't really tell for sure, but this is a general perspective. If the doctor takes an X-ray, nothing shows up. I mean, of course, obviously the doctor is not going to do a bronchoscopy, so there's no evidence that he has the disease, and he's not complaining of any clinical symptoms. Okay, so if the question is no evidence of disease as far as the clinical examination is concerned, and not complaining of any symptoms, then that's the stage of susceptibility. And the reason why this kid wants to quit smoking is because he doesn't want to end up with emphysema, COPD, or lung cancer. He doesn't have it yet, so he's just susceptible. Okay, so that's the stage of susceptibility. The patient does not have the disease yet, but he is getting exposed to, or he will get exposed to, the causes or factors for the disease to start. Okay, the exposure to or accumulation of factors sufficient for the disease process to begin in a susceptible host. Now, for infectious diseases, the patient is exposed to an infectious agent. That's why we're giving the vaccine. For cancer, the patient can get exposed to factors that may initiate cancer, like components of tobacco smoke, or one that promotes the process, such as estrogen, which promotes endometrial cancer. Now, if you have an elderly male who's asking the doctor for help because he wants to quit smoking, he doesn't want to get sick, and the doctor runs through the list of symptoms and he says he's not feeling anything, so he does not have any clinical symptoms or manifestations, so he does not have any complaints as far as the patient is concerned. I'm not feeling anything, but he's kind of old, and the doctor wants to make sure, so the doctor does a couple of things, does an X-ray first, and then ends up doing a bronchoscopy. Let's assume that he did that, and he actually found evidence of disease with the test, but the patient still says, I'm not feeling anything. So there's disease and there's no symptom. So the patient is subclinical. There's the presence of disease, but there's no clinical symptom that goes along with it. Okay. Another example would be someone like an elderly female who had a screening test for osteoporosis, and it turns out that she really does have osteoporosis. And then the patient's wondering, well, how can I have osteoporosis? I'm not feeling anything. Of course, we all know that you don't feel anything with osteoporosis. You feel something when your bone breaks. But, if your bone is thin, it feels like it's still working, right? So you have someone who's not feeling anything, but you have the test showing that he or she already has osteoporosis. Now we have this young lady who's getting her annual pap smear. So her screening pap smear is a cancer screening test, meaning we're screening for cancer, which hasn't manifested yet. So we're screening everyone. Okay? We're not doing the pap smear on someone who's complaining about something. So this is a screening test for cancer. Therefore, she doesn't have the problem yet. So if the pap smear turns out negative, then she's just susceptible. Now, unfortunately, the test showed that she already has something going on in the cervix. So the pap smear was positive. If you ask the patient, of course, initially, dysplasia or even a small cancer is not going to cause any symptoms. So she's not feeling anything, but the pap smear revealed that she already has it. That's subclinical disease. Subclinical disease starts from the time of exposure to onset of disease symptoms. It begins with the exposure to the onset of disease symptoms. After the disease process has been triggered, pathological changes has already occurred, but the disease is inapparent because the patient is asymptomatic. Now, the stage of subclinical disease is also called incubation period for infectious disease. So it's incubation. Now, for chronic diseases, which are non-infectious, it's called latency period. So incubation period for infectious diseases, latency period for chronic diseases. This stage may be as brief as seconds. For example, allergic reaction, hypersensitivity reaction, that's really fast. So that's a very, very short latent period. And it can also be long or even decades. Like some chronic diseases gradually develop and advance slowly for years, or it takes months for the chronic disease to manifest itself. It can be brief, it can be long, and so that's the subclinical disease. Now, again, the patient is asymptomatic, the disease is inapparent, but pathological changes may be detectable with laboratory radiographic examination or screening methods. Now, most screening programs, like cancer screening tests and such, try to identify the disease process during this stage. Of course, you can only identify a disease if it's actually present. So the disease is present, the patient comes in, they're not coming in because they're feeling anything. They're coming in for an annual screening test, and the test finds something, therefore that disease is at the subclinical stage. Now, the reason why we're doing all these screening tests is because intervention at this early stage is likely to be more effective than treatment given after the disease has progressed and become symptomatic. Now we have this elderly male. We saw him before a few years back. He came to the doctor asking for smoking cessation, and the doctor helped him with that. Now this time, he's feeling something already. So he's saying he's becoming short of breath. He noticed that when he climbs the stairs in his house, before he's not short of breath, now he can't even go halfway and he has to stop to catch his breath. There's dyspnea, shortness of breath. He's symptomatic. And the doctor takes a look at his lung, does the x-ray, maybe does other testing like spirometry or pulmonary function testing, and finds that the patient has COPD, lung disease. Okay, so he has a disease that's clinically manifesting. So this is the stage of clinical disease. The patient at this stage starts to have symptoms. The onset of symptoms marks the transition from subclinical, where the patient doesn't feel anything, to clinical, where the patient feels something. So this is the clinical stage. Most diagnoses are usually made during this stage. Why? Because people usually go to the doctor when they're feeling something. So a lot of disease diagnosis would be made during this stage. Of course, it's very difficult to diagnose a disease when the patient is not symptomatic. For one thing, they don't go to the doctor. We can only diagnose that when we do annual screening tests to look for cancer that is not symptomatic yet, or to look for other diseases like diabetes that is not causing any symptoms yet. In some people, the disease process may never progress to a clinically apparent illness. In others, the disease process may result in illness that ranges from mild to severe to fatal. We have this spectrum of disease. So when we talk about the range of illness from mild to severe to fatal, we're referring to the spectrum of disease. Now, the last stage is the stage of recovery, disability, or death. Again, if we don't do anything and just let the disease go, well, it should end up somewhere. It either gets better without any residual, so full recovery, full resolution, or it gets better but leaves something behind, so a disability, or the patient dies. So it's the stage of outcome, or the stage of recovery, disability, and death. Okay, this picture, this colored picture, is Ebola. Ebola was big news a few years back. It's very pathogenic. Okay, description is the pathogenicity between different subtypes of Ebola does not differ greatly, and they're associated with hemorrhagic fever outbreaks. Ebola in Zaire and Sudan strains are especially known for their virulence, with 53 to 90% fatality rate. So it's very fatal. Infectivity is measured as infectious dose, meaning the number of microbes necessary to initiate the infection. The Ebola virus can infect a host if only one virus comes in contact with skin or mucous membranes. Now we're going to talk about the terms. So we mentioned infectivity, right? So the Ebola is very infectious even if only one virus comes in contact with the skin or mucous membranes. The patient or the person will get sick. Okay, so infectivity is the proportion of exposed persons who become infected. How infective is the infectious agent? Pathogenicity is the proportion of infected individuals who develop clinically apparent symptomatic disease. They're not subclinical. This is the number of people who are subclinical who become clinically symptomatic. So that's pathogenicity. Virulence is the proportion of clinically apparent cases that are severe or fatal. A lady is talking to her doctor, and the doctor says, your hepatitis B test results show that you have the virus, but she's not feeling anything. Carriers. Persons with incubating or inapparent infection may transmit infection to others. They are infectious but have subclinical disease. They don't have any symptoms. They are symptomatic, but they can infect other people. Okay, for example, you have measles, hepatitis A can become infectious a few days before the onset of symptoms, so people can get it from the person who is infected, so they're carrying the infection and they can transmit it. Now, some people are walking around carriers. So you've heard about chronic hepatitis B infection in someone who's not feeling anything. So that person is a chronic hepatitis B carrier. That person can infect other people, but as far as that person is concerned, the hepatitis B is not doing anything, he's not feeling anything, it's just there. Now, they appear to have recovered from hepatitis B, or they appear not to have hepatitis B, but they are infectious. So that's a carrier. Okay, now we're done with the bio part of the biopsychosocial approach to disease and illness. Of course, there are lots and lots of generalist perspective bio approaches to the biopsychosocial approach to disease. Social work would have lots of them, even nursing. General medicine would have, family medicine would also have other approaches or other models or other frameworks. But as an introduction, we'll stick with the natural history of disease. So the general idea is that disease goes through certain stages. Now, we'll go to the psychosocial part, and we'll start with the idea of disease, illness, and sickness. In very simple terms, the disease is the biomedically defined pathology. So when you open your pathology book, that's the disease. So pretty much 80 to 90% of whatever it is you're going to end up remembering and memorizing in med school is something to do with the disease, because right now everything is very biomedical. Illness is the subjective experience of the person who got the disease. So the person who has the disease experiences an illness. Sickness is a socio-cultural concept. So people write about sickness. People know you're sick when your doctor says you have a disease that makes you feel ill. That's one way of memorizing it. People will talk about you, and the community will talk about your sickness when your doctor diagnoses you using tests and tells you this is the disease that you will have, and you will experience feeling ill. So the experience is the illness, the disease is the biomedical pathology. The biomedical types of illness are based on biological criteria and is meant to establish biomedical diagnosis and treatment plans. The psychosocial types of illness links the biomedical types to the psychosocial effects of the disease. So now we're going to talk about the illness and the socio-cultural and the family and the community reaction to the illness, or the patient reaction to the illness also. Again, for complex systems, or even individuals are complex systems, you can have several models and approaches coming from several fields. For this session, we're going to use the ones presented by Dr. John Rolland. He presents the time phases of illness and the psychosocial typology of illness. For the time phases, if you look at the picture, it's very similar to the natural history of disease, because they both deal with the time course or the history of the illness or the disease. But his model is focused on the subjective experience. So this is the time course of illness. The other one is the natural history of the disease. Very similar. Of course, the big question is, how come Dr. Rolland didn't just use the natural history of disease and describe the psychosocial impact? Well, he didn't. For one thing, he's not an epidemiologist. He's coming from another field. And as far as he's concerned, it's easier to describe the psychosocial reaction by dividing it his way. So this is his way of dividing it. But if you put the two side by side, you can actually see how they would interact. Now, what he said was to create a psychosocial schema of chronic disease, the developmental time phases of an illness can be considered as the second dimension. The big problem is most doctors don't pay attention to the second dimension, which is the psycho-emotional impact of the disease. Okay. The concept of time phases provides a way for the physician to get a fuller understanding of the chronic disease as an ongoing process with landmarks, transitions, and changing demands as far as the patient is concerned. Again, we're talking about the disease experience. So if we look at the time phases, for each phase of the disease, the illness experience would be different. So that's the general idea. Simple, easy to use course. He just separated into three. The crisis phase, it's pre-diagnosis. He gets the diagnosis and the initial adjustment. So it's everything is in the flux. So the emotional reaction, the social reaction, the reaction of the family will be different during that time. And then after all that excitement, there's so you have the chronic phase. The phase is patients getting treated, being monitored by the doctor. He's waiting whether he's going to get better or not, or whether his disease is going to get worse. So that's the chronic long course. Okay. And then the last part is the terminal part. It ends in something. Either the patient gets better or the patient dies. So that's the terminal part. So three phases. Next is the psychosocial typology of illness, or the psychosocial types of illness, as presented again by Dr. John Rolland. The typology conceptualizes broad distinctions. We have the onset, the course, incapacitation, outcome, and uncertainty. Meaning, it is hypothesized that these categories are the most psychosocially significant when we try to figure out the illness reaction of the patient and the family. So it's useful to think in terms of, number one, onset; two, the course of the illness; three, the degree of incapacitation; four, the outcome; and five, uncertainty. So we'll discuss them, or we'll describe them briefly one by one. So for example, the onset. You can imagine there's a difference in the psychosocial experience if the illness is acute, like someone who suddenly experiences a stroke, as opposed to someone with a gradual onset disease, like someone who starts having memory problems and he knows it and he's getting worried, and then it gets really, really bad. He goes to the doctor, he gets told that he has Alzheimer's, and it progresses, and then suddenly he can't think anymore, he cannot remember names, it impacts his family, it impacts himself, and then the patient dies. So the entire illness experience would be different from someone who suddenly gets a stroke, gets debilitated, and dies, as opposed to this gradual Alzheimer's disease pattern that I just described. Our patients would also have different disease patterns, like COPD would have a disease pattern. Cervical cancer, the one we discussed, would have another disease pattern as far as onset is concerned. Now, next one is course. So if we talk about course, we can say a disease can be progressive, like a cancer that keeps on getting worse and worse and worse. So there's a progressive course of cancer ending in death. So you can imagine the impact would be different as the disease worsens and more complications happen. The treatment gets more difficult. There's a financial aspect to it. There's an emotional, very heavy, burdensome load as far as caregiving is concerned. And there's lots of emotions going on as far as the friends, the family members, and the patient himself, especially if the cancer will end up killing the patient. As opposed to progressive, you can have constant. Like, for example, spinal cord injury. Patient injured his spinal cord and it doesn't progress, it's just there. So now you have a debility and you'll have this debility for the rest of your life. Now, the psycho-emotional impact of that would be different. You can have a course that's relapsing or episodic. Like, for example, asthma. You get worse, you end up in the emergency room, and then you get better, and then you act normal, sort of, and then you get worse again, and then you end up in the doctor's clinic. So the impact of that on and off, better, not, hospitalized, ER, home, would be different. The psychosocial impact would be different. If we talk about incapacitation, we can think of impaired cognition. The disability would be in terms of cognition, like brain cancer or Alzheimer's. The impact of that would be different as opposed to an impaired sensation, like you can't see well because you have cataract. Okay, you can still think well, your memory is good, but then you can't see well. Well, the impact of not being able to see well would be, of course, different. Now, impaired stamina, like, you can't run well, especially if you like doing sports or exercises, that would also impact on the way you do your daily routine. If you like exercises, and the way you perform in your job might also be affected. That's impaired stamina. And associated social stigma can also be considered an incapacitation, like having HIV or even COVID nowadays might be considered by some in some communities as sort of a stigma. I mean, it shouldn't be, but sometimes it is. The extent, the kind, the timing determines the psychosocial effect of the incapacitation. Now, next one is the outcome. Now, the outcome can be different. It can end up with death. Of course, person who's dying would have a different psycho-emotional reaction to what's happening. The family would be reacting also differently as opposed to, or as compared to, someone who's not yet dying but who's been told that they have a shortened life expectancy, as opposed to a family reacting to a family member who suddenly dies, like a sudden massive heart attack and the patient's dead. So, you can imagine a different sudden shock reaction of the family. So that's the psycho-emotional reaction of the family. Of course, it's too sudden. The patient probably won't have a lot of time to react, maybe just a few minutes or seconds, but the reaction of the family will be different to something that's sudden compared to something that's not so sudden, like cancer that ends up being terminal or fatal several months later on. Now, the level of uncertainty or unpredictability also plays a role. You can imagine if something is very unpredictable, then there's a certain degree of anxiety and fear going on, as opposed to something that's more controllable, very predictable. The doctor can easily tell you it will probably head this way and be less anxiety, as long as what's predicted is not too worrisome. The uncertainty and the unpredictability has an impact to the degree usually of anxiety or fear involved in the illness experience. So that's the psychosocial typology of illness. That's the end of the session. Okay, so what happens next is, now that you know the illness part or the disease part, you have this thing, the disease goes through the natural history of disease stages or the phases and the psychosocial types. The idea is to figure out how this interacts with the person, which is another lecture. So how the person reacts cognitively, emotionally, socially, etc. And then how the family reacts to the patient and the illness for different stages, for different phases, for the different psychosocial types of illness, how this impacts the family. Of course, the family would also have different types and different life cycles. And you might even consider the community. How would the community react to the disease in various stages, in various phases? So that's how this lecture fits in the idea of the biopsychosocial approach to illness using interacting elements. So interacting illness with the patient, with his family, with the community, with his healthcare providers.